Okay, so we know that everyone obviously spent a lot of time discussing their questions and existential crises with their groups. So we also wanted to make sure you didn't feel left out and that you weren't hearing, everyone's conversations. So we are going to have a little bit of a large group discussion, mostly so you can have existential crises about other people's questions. So would any one of our group leads like to go first? I was like, Meg and Jeremy, get up here.
Well, you have it listed up there first, so I thought anyways.
That's true.
The sooner we talk, the sooner comes lunch.
Holly, you want us to talk for like 2 minutes?
Yeah, 2, okay.
And also results. Are we doing results or is that later?
I mean, you can talk about the questions you guys picked.
Do we see them?
No.
Seen them. Okay, so then we can talk about what we talked about picking. Okay.
Yeah, so I think it's, okay, so what's gonna happen is they're gonna talk about large themes from their group, and then you guys can discuss your thoughts about what y'all talked about.
Thanks, Holly. Okay, so we were in the coaching and individualized learning group, and it was so helpful to hear the Canadian experience this morning because it really influenced our questions. The sort of big things we talked about are really trying to define how does coaching affect CBME, what is that intersection, because there's so many different things you can talk about with coaching, and we really drilled it down to the sort of what outcomes can coaching really affect in CBME? How do you train the coaches? What is that sort of minimum requirement needed? What is the learner perception of it?
And that was a big part as well, particularly because the experience that our Canadian colleagues related was the unintended consequence of how the learners perceived what was going on versus what was meant to go on. Mm-hmm. And I think even in a non-fully competency-based framework, we all see that now with how we try to assess and get people to this growth mindset. But we work in a system that absolutely inculcates a performance mindset. Yeah. So that problem and helping to know that in advance, to know that that's a big challenge, I think was a big part to not forget the learner experience.
Yeah.
And then, now I'm trying to forget the rest of it. Some of it, we talked about a little bit of the technical formats, like frequency, the in-the-moment coach versus the longitudinal nature. What is the special case of remediation, which I think is even more of this problem of performance and I must meet a competency standard versus help me, I'm trying to get better and I have to be able to show that to be able to get better, and where does that tension lie? Trying to think, was it 4th or 5th? We actually, at least in our experience, we got fairly close to, I think, probably what our top 3 questions will be, and hopefully this is what will be reflected in our numbers. Maybe it'll turn out entirely different. Any questions from the group? How you wanted to field some open questions from others, right? If anybody had questions on the coaching and individualized learning perspective. Come again? Yes.
Oh, good question.
Yeah. Yes, that's an important point. We had that same thought in our group on the other groups of what their questions may be focusing on, and this leads to the trouble of you want to prepare learners for all of competency, but that's not the job in the coaching sphere, right? We want to be able to make them be prepared for coaching, but they all overlap. We have questions here?
Yes.
What do you think? Okay.
Yeah, so our ones that have bubbled up, we're going to word these differently, so don't worry about the wordsmithing for now. But what short and long-term outcomes should be used to assess coaching effectiveness in CBME? So basically what is it good for? What does it actually work for? How do we train competent coaches for coaching learners in CBME? What did we make this one?
Yeah, the original question from the Delphi had framed this in terms of what structured tools are needed, but we reframed that more about what are the data inputs. So it could be a tool, but it could be other forms, right? The off-the-cuff after work or after shift feedback can be a part of that. Your competency committee, if you get something as a product from them as a learner, that could be a bit. So what are the data pieces?
And then the last one is how do trainees perceive the coaching process? And so this is really, this was already something that kind of came through in the Delphi process, but then after hearing the Canadian experience this morning really has bubbled up, is this needs to be first and foremost as we're considering these things. Yeah. Anybody in our group, is there any big stuff that we missed?
Great. Thank you very much. Let's hand off to the next group then.
Who wants to go next? Don't make me make you. Okay, don't all jump at once. Martin, yay. Martin and Kendra, assessment. Feel free to be as provocative as you want.
We had a big group, a big functional group, and so that so we got done with time to spare, which I think is quite an accomplishment. So congratulations to our group.
Yeah, it's because we have 6 questions still, Holly. No, I'm just kidding. I'm just kidding. So a lot of our conversations, we talked a lot about like validity, reliability, feasibility, like how do we make sure we understand the current tools that we're using in assessment, and then what are the gaps, what are things that we feel like we don't have tools for that maybe we should, so really kind of doing a survey of our current landscape. We talked a lot about making sure we're thinking about like patient-centeredness and bringing that lens to the assessment tools, thinking about the place for like patient outcomes, patient care metrics in both the larger system of assessment, but also within individual, progress and promotion decisions and competency decisions for the learners. We had a small conversation about burden, recognizing that it falls into multiple groups and was something that was really highlighted this morning. And so our group decided we feel really strongly that it should be represented somewhere, but probably like our group isn't the one to bring that forward. Yay. And then we also talked about standardization. So like what components of assessment need to be standardized to allow for meaningful, data aggregation and analysis versus where can there be flexibility so that the system can be adaptable to local contexts.
And then we also, one of the questions we voted off the island was a distinction of non-technical skills from technical skills, with the idea that that distinction is probably not helpful, they're skills, and that our assessments should be about skills and the interplay between those skills. We also talked about predictive analytics and the influence of AI. And so to what degree should that be its own category? Or should we acknowledge that it's going to permeate our assessment systems and therefore on a skill-by-skill basis then think about the inflection of AI within that? So in the end, we have a question around predictive analytics, but we're not specifically calling that out as a separate research thing, but rather that it will probably color all of our final questions and should properly do so. And then the last one was equity and bias. Do our assessment systems reflect the biases of our society, and to what degree can we use them as a tool to mitigate those biases? And so those were the considerations we came across with. Anybody from the group want to raise anything else that we discussed? Good. So we did boil it down to the 5.5, 6 the questions, and so and so thanks, group.
Oh, Jamie and Joel just got up. That was easy. Apparently we're going in order. All right, cool. Faculty and learner development. And again, if you have questions or you're like, that doesn't make any sense to me, or I have something to add, please feel free to speak up.
So we were super lucky that we only had 8 questions to begin with, and so to get down to 5 was actually relatively easy and a consensus from that standpoint. Hopefully we all voted correctly, so those are the 5 questions. But and a lot of it really we looked at is educational strategies as far as implementation for both faculty and learners. We also wanted to look a little bit about some of the unintended negative consequences to try to anticipate those and try to teach those toward development, to try to not, to anticipate and not have to deal with the problems later. We also talked about the hidden curriculum and some external cues or feedback that patients may get, that learners may get, and then how to do that. And then things also as well, kicking out the assessment questions, because we had an assessment question we deferred to the other group, but also how do we develop faculty in a way that we can help to mitigate some of that burden.
All right, so I'll just share, and we are still wordsmithing, we're planning on wordsmithing a bit, but are the ones that we ended up with are, what educational strategies are most effective in preparing learners for the successful implementation of CBME? Is a shift from a time-based to an outcome-based system of trainee advancement achievable within the existing ACGME structure? And if so, what faculty and learner development strategies would best support this transition? How do learners navigate the milieu of formal versus informal feedback in CBME, and how do learners judge the credibility of their various forms of feedback that they seek and receive, and how can we prepare them to be able to do this? And then what are the negative impacts of a CBME system, including assessment burden on trainees, faculty, and patients, and how can these be mitigated with faculty and learner development? Questions for us, or anybody from our group, something that we forgot to mention? All right.
All right, thank you.
So implementation and change management kind of sits on top of everyone, so we've all been totally paranoid about like stepping on everyone's toes. So
wanted to thank our group, really elevated the conversation, and would love your help in some of the questions that came up. For example, we looked at our questions and started lumping them, and then also looked at our questions and we're trying to figure out if they were research questions or tactics, as an example.
yeah, so we ended up merging total of two groups of 2 questions. So we cheated a little bit to get down to our 5, Holly. It's all documented for you. We really came down to a summary statement, and two of the groups of questions we were asking really had to do with a validity argument for the use of CBME as a system. We're trying to move it out of just the EPAs or assessment tool, but CBME is a system including considerations of outcomes, consequences of use in relationship to other variables as one very broad question. We also delved into the local variation versus system validity issue. We were looking at the assessment at the system level on what is the burden, or how do we understand the proposed burden of assessment and develop strategies to mitigate it while maintaining fidelity at the learner level. And a broad level question about the implications for CBME implementation on the individual and system level with regard to finances and workforce, and anything else anyone wants to riff off on. And then how do we measure the success of implementation of CBME on a program level? And that's what we're honed down to at this point.
Any other thoughts from our group or the audience in general?
Okay, I'm going to poke at some of this if nobody else is going to. So I'm curious from the change management lens, and I'm going to open this up to everyone. I think there is a question about how do we know CBME is successful at the program level versus how do we know CBME is successful at the specialty level? And I'm curious how folks are thinking about that. And I'm going to open that up to everyone in this room, including our speakers who've thought about this in perhaps a very different way. Go. Go to Ben. Yeah, it's you, Ben.
Okay, I wasn't sure. I thought somebody over there was going. I love that question, Holly. And one of the initial questions that was on our list related to trying to find associations between competency-based assessments and patient outcomes. And I think that is a really interesting and important and fraught endeavor. because I think sometimes we think that is how we will ultimately judge success or failure of our educational initiatives, because the promise of CBME is to improve patient outcomes. And there was a really, first of all, let me be clear, I think we should endeavor to find those associations if they exist, and have the nuance to understand that we may never find them, even if CBME or any other educational initiative is successful. There's a really interesting paper written by John Sherbino and Lara Varpio that talks about this, that the links in the chain between an educational assessment or an educational intervention and a downstream patient outcome are so myriad and so complex because of all the things that go into patient outcomes, we may never find that pot of gold at the end of the rainbow. Even though there are some studies that show like these milestones correlate with these surgical outcomes, the signal's always small and messy and it's inconsistent. And so I just think there's a lot of nuance around that. And I think it's important if we start chasing down those things as a measure of program evaluation or evaluation of the theory of CBME, to understand all that nuance, that if we find something great, it may or may not be meaningful. If we don't find something, that doesn't mean that it doesn't necessarily work.
Yeah, I think you're making the point. I think Teresa Chan's the one who said it originally, and I've kind of picked up on this. It's the idea of, NASA has to launch rockets, right? That they don't know if they're going to make it to the moon. They know that eventually one of the ones that they try is going to make it, but they have to test the component parts. That's why if you go to NASA, there's a bunch of dead rockets in the backyard. So knowing that CBME works, getting the rocket to the moon, we're kind of in the position where we're kind of testing the component parts, and it may be hard to know that it's going to make it all the way to the moon until it actually makes it. Andrew.
I'll just weigh in. Thanks for that really reflective thought, Ben. And as part of our international CBME collaborative, we built a bit of a taxonomy of outcomes related to CBME. And without diagrams available, I'll try to just kind of summarize. I think this component parts might look at dividing up and thinking of all of the different outcomes that we might want to start measuring and picking at them in little individual ways. So there's educational outcomes, and then there's like clinical outcomes. So you could say an outcome of implementation of CBME is more effective feedback provided to residents in training. That's a very positive thing. That would be an educational outcome. You can think of short-term outcomes, medium-term outcomes like in the transition to practice, and longer-term outcomes with physicians out in training now, or out in practice now. And then you can look at also the different levels of outcomes. So micro level outcomes at the program level, micro at the individual program level, meso at the like discipline or region, and then more national outcomes. And so all of this can be conceptualized. And I think if we're going to get into outcome measurement, the most important thing is to say, well, which ones are we going to focus on and how do we do that well, rather than being overburdened by trying to do it all. But I think being focused in our outcome measurement is probably the most effective way to move this all forward. And if we're all doing it, then we'll eventually have a big, huge bunch of outcomes measurement.
Yeah. So I saw Felix and then John, and then we'll go to the back, and then, so gray jacket over here.
I mean, it's a great question, and this is from AMEM being an organization that organizationally tries to be structurally humble, but when we hear the words, the specialty, at least we perk up a little bit, especially in terms of assessments, outcome, competencies, et cetera, that our board certification is just one element of that, and we're working towards the outcomes that you mentioned, a linking board certification to better outcome for patients or loss of medical licensure and all that. So we want to be a partner with the educational outcomes and to link, let's say, some of the assessment parts of CBME, whether it's the linking the EPAs, the terminal EPAs of residency to the elements for board eligibility, whether it's the program director attestation, or looking now as we are shifting to be more patient-centered, some of the cases of a certifying exam and all that. So we're very interested in collaborating and helping to really define what that is, and maybe collaborating on big data after that. What is the residency impact on care on a major level, and then what is the impact on continuing certification in terms of big data. As an example, if the care for stroke is changing, and we have 40,000 diplomates, how do we make sure that works? If we have board eligibility and we look at certain elements of board eligibility that don't correspond to terminal subnivia, how can we build a bridge around that? So I think it's a dynamic system, the dynamic system from self-assessment to workplace assessment and independent assessment. But I think we have an opportunity, because there's magic in the room, and I think there's magic in emergency medicine as we go towards the future. So thank you.
All right, over here to John.
Thanks. I prefer not to shout, so thanks for waiting for the mic. I think it's an interesting question, Holly, and I will say my mind actually went in the opposite direction. I think there's thinking about practice, training site, but I also think that we should be thinking in the opposite direction about individuals. Mm-hmm. And there's a lot of assumptions built into the conversations I've been listening to, namely that we're assessing performance in one context with the assumption that that performance will be manifest in another context where the research or the resources and the ways in which folks are interdependent with those resources are totally different. And so, I heard the word adaptive expertise this morning, and what's interesting to sort of listen to the conversation is I don't see that being measured. And I think I would encourage us to think about just the ways in which we are sending people into practice with this sort of promissory note that they're going to figure it out. And that maybe we should also be thinking in that direction towards the individual and what's unique and idiosyncratic about these experiences in practice that are so different from where they trained. And I think there's some opportunities to be a little bit more perhaps flexible in how we think about expertise, because we are a totally biased sample of our context and our resources.
Yeah, and while the mic goes to the back, I'm gonna highlight two things that I think, trying to connect the dots from what we heard earlier to what you just said. So, Andrew, you want to shout context matters again? I think that is incredibly important. Context 1000% matters, and we've noticed that in our pilot. I mean, every site is wildly different, and what becomes acceptable variability, what's not. I think that's incredibly important. The other piece is we don't assess adaptive expertise. And Ben, what was your favorite quote? It's more important to teach people how to think. So I will say we're redesigning our assessment system for the School of Medicine at Stanford right now, and actually one of our domains that we're assessing explicitly is adaptive expertise. And I think that that may be something we want to consider within emergency medicine as we move into CBME. To the back.
I just wanted to echo what John mentioned, because it was part of what I was going to come into, where the context is so important for the dead rockets as well. I mean, each dead rocket is probably a learner who is getting out of this not taking into their repertoire of what they are competent in or not. But I think that one thing that's a big, I would think that's a big difference between like the Canadian system and what we're doing is that they started off from the top bottom, and it started off with the RCS and then kind of went down is what I kind of gathered. Whereas like here, it just depends on like individual boards, and it depends on, the ABP has started from top bottom versus the AAMC is doing something versus the LCME is doing something else. And so when we have med students come in from a med school where it has been implemented where the AAMC EPAs have been implemented for them, and they go into a system where it doesn't get implemented or is a very different system, whether that changes outcomes by themselves. And that might be something worth looking into at an individual level, see where they're coming from, where they're at, where they're going from there. And I think that's what John had mentioned as well. And I think it's a very important thing to probably look into.
Yeah. I'm going to go to Rob, then to Mark.
I want to circle back to something that you just kind of alluded to, and it's actually a question that I have of the assessment group, is do we need to consider when the assessment starts? Because you had mentioned skills that are now going back into the medical school. We've got accelerated programs that are starting to pop up around the country. And from our Canadian example, they almost have this transition to training period where they kind of validate that skill set when they enter their residency programs. And so do we need to actually think about backing this up into the medical school in order to then accelerate through the residency pathway?
Yeah, thinking about the continuum. Mark.
In thinking about your question of what would be a way of assessing whether CBME has worked, I think looking at learner-oriented outcomes from an experiential perspective is probably really important as well. Because historically we know we do damage to our learners. Sometimes that damage is severe, and we're trying to move to a model where we're doing less damage. And I think that is something that's actually fairly easily measurable.
Come right here.
Just a comment. I think what you mentioned about like what determines like the success on a specialty level. So it depends. There's so many different facets of what we define as success, right? Is it recruiting more people to the specialty? Is it just focused on patients? And is it ultimately professional satisfaction? So all of those things are going to be markers. And so I think, you know, as we look at this, those are all going to be things that we want to assess, or my assessment team group, you know, those are all among the things that we assess, not just the specific discrete you know, competencies or whatever we define as competencies or whatever we're defining in the milestones as that part of the rubric, right? There's all sorts of other things that we are assessing in general as measures of success of each of the individual, I think, interventions that we discuss and propose.
And getting back to Andrew's point, that taxonomy paper, I believe we broke it down as, was it individual, program, specialty, system. Yeah, there was a big kind of hierarchy of outcomes when you think about evaluation. And then, shameless plug, there's going to be an evaluation paper that comes out that talks about different methods of evaluation, but thinking about, you know, do we use a realist evaluation, you know, to look at what works and for who and what context and why? Do we use a learner-oriented, do we do a stakeholder analysis? You know, what does this look like? And I think it's going to be a myriad of different options to really try and figure out what's working and what isn't and what we need to do to change, because I think it would be foolhardy to think we're going to get this completely right when we scale up the very first time. So, other thoughts? Otherwise, I will let you guys go eat lunch. Nicole, how long do we have? 1:15. All right, you have 1 hour. Be back here in your seats ready to go at 1:15 because that session's going to be really fun. So, 1:15. Lunch.
Good afternoon, everyone. I'm sorry to interrupt, especially your dessert portion of the lunch. My name is Alex Sheng. I'm the Residency Program Director at Brown University Medicine. I'm also co-chairing the Consensus Conference for SAEM next year on health misinformation, which is unfortunately a very timely topic right now. You all know that patients who are victims to health misinformation are at our doorsteps in the ED pretty often. Whether it's from vaccine hesitancy, refusal, from taking toxic substances they found online, or just delays in care from just using a bunch of ineffective treatments they found on TikTok. But the issue is the impact on patient outcomes, especially in emergency care, from health misinformation is pretty much completely unknown. There's a dearth of literature on how physicians can properly address patient misconceptions, whether in person or online, and there's certainly no established curriculums or training programs to help our trainees do that. So please help us help address this important issue, fill some of these gaps. You can come to the Consensus Conference next year. This is the save the date. And for those of you who are interested in putting in effort in a working group, please do so as well. And I'll be here for the rest of the day if anyone has any questions. Thanks.
Yeah.
Okay, guys, welcome back. Thank you for sticking with us. We have a panel, a reactor panel, who's really going to talk about kind of the things that they've heard, some of the pressure points, tensions, and really just kind of reflect on where we've been so far. And again, then we're going to get into kind of some of the cutting edge stuff around coaching, precision education, and then you're going to narrow down your questions. There's going to be a final vote, and we're going to get out of here. It's going to be a great afternoon, and Tiffany's already laughing at me. Thank you, again, thank you for sticking with us, and with that, I'm going to pass it off to, who's going first? This is promising. I'm just going to hand this to you. You can tell. There you go.
Okay. Hi. So hi, everybody. Tiffany Morano from Columbia. First of all, let me just say that this is amazing work, and thank you to Holly and the group for inviting me to be on this panel. I got the sense that there are some common themes throughout each of the groups. So one of the common themes is like burden, mitigation of burden, outcomes. So how do we assess, the effect of CBME on our patients, our trainees? What does a successful CBME program look like? There's also, it's going to require a lot of preparation for the faculty and the learners, and then perceptions from the learners and the faculty, as well as educating not only our faculty, but our learners on what CBME is and why we're doing it. I will say for me, in terms of like one of the things that maybe we're not talking about, in terms of assessment, listen, I can tell you what happens at my shop, and I've spoken to a couple of people across the country, and it's really hard for us to get faculty to do assessments. It's really hard. I mean, it's pulling teeth. And one piece of that is that if it is perceived by our learners, specifically the residents, if they're getting negative feedback, it's almost like they weaponize the faculty evaluations, and it has a downstream effect. So it's kind of like a vicious cycle. Our faculty don't want to fill out evaluations because they're afraid of being honest and afraid of what the learners, what's going to land on the learners' ears, and then maybe are they going to retaliate. So our numbers are kind of low, and we're doing a lot to educate our folks on how to give feedback. But I think that that's going to be a really key component moving forward, is how to deliver information that is constructive in a way that it falls on ears constructively.
My name is Martin Pusick. I'm a pediatric emergency doctor at the Boston Children's Hospital, and I have a research role at the American Board of Medical Specialties. And I just want to pick up on what Dr. Morano said in terms of the perceptions. And I think that within this effort, there's an important framing, signaling element that we need to have permeate through our community. And so in convening a conference like this, I think it's a step towards that. CBME is a higher ambition for our learning. And so that, so if you just take the assessment burden aspect of it, imagine how cheeky it was to think that we could do a end of rotation evaluation. So one single form gets filled out on you, and that sampling rate of one form per month was the way that we would draw a signal in terms of the competency of our learners. And in fact, in medical schools, it was such a problem that that medical students were learning on the last day of their rotation that they were failing, that the LCME mandated mid-clerkship feedback. So they would then double the number of evaluations, one in the middle of the month and one at the end of the month. And so now, kind of in terms of having a conversation about burden, and the Canadians suffering for, kind of once a month, kind of out of sight, out of mind, to 200 evaluations over the course of a month, and people complaining about the 200 being too much, and us not being able to get people to, kind of do enough to hold it across. At least we're having a conversation now about how much is enough. How much is too much, and kind of what is the nature of each of those 200 evaluations. And so we're going to settle into some kind of thing. Andrew's going to tell us that it's 78 that we need each month as you go across. And but think then beyond that to the ambient AI possibilities of every single conversation being somehow pulled together and assembled in a frictionless, low burden kind of fashion and bringing it across. And so that, so again, I think what we need to signal to our learners in terms of changing the culture, which is kind of what this needs to do, is that this sampling is for a purpose. This sampling is for making you good, and that ultimately, in a co-creation kind of fashion, we can together come up with a culture that respects the difficulty of being a really, really, really good emergency physician. And so that, so I think that notion of a higher ambition, that we're doing this in order to be better, we're not doing it just to change, and that the way we would be better is to step off of the once a month thing to something better, and now let's argue and have a higher level discussion about what is better, akin to what we're doing here at the conference.
I don't know if we're going to keep building on each other, or do I summarize and stop? I mean, I think just moving from the two before. Oh, sorry, thank you.
Everybody knows Sally.
I always forget these things. I'm Sally Sand. I'm at University of Cincinnati. And I lost train of thought. So I think what we're all struggling with is how are we going to get our faculty and our learners to be able to get that number of assessments, right? And I guess what I often come back to is where are the bright stars, right? Where are the places where this is actually happening, where people feel like where the residents are engaged and the faculty are doing it? Like if you look across, are there places where there are a ton of evaluations or assessments of residents being done, and the residents are feeling good about it? And so I think if you feel like you have a bright star, you should step forward and help us learn from that. I think I have learned a huge amount from Eric Worm in internal medicine at University of Cincinnati. I think when they graduate, their residents, they have like thousands of assessments on each of them, and each one of those assessments has an expected score, so it's corrected for hawk dove and all this other stuff. And so there are some gold-plated, excellent models out there, and trying to figure out what they are so that we can do better.
Ben Kinnear, also at Cincinnati, not an emergency medicine physician, I'm sorry. I'm kind of looking at this as an outsider. And I just literally, right before this conference, I was in Chicago at another conference. Holly was also there, and it was a meeting with all the specialty boards, or many of them, and the ACGME. And I want you to know how far out ahead you are of many specialties. Emergency medicine is one of the leading people, even though you all are right here in the trenches struggling through the hard parts of it. A lot of other specialties are looking to you. You're way ahead. And so I just want to thank you for that, because some other specialties are way behind, and you're not just clearing the way for your learners, but you're clearing the way for others. And it's really cool to see. I'm sorry, what did you say?
Internal medicine.
Yeah, that's what he said. I don't want to say laggards, but we are. So that's one reflection. The other one was at that meeting, one of the things that I did was I shared some of this outcomes data with just non-physician parents about pediatric graduates. And this really interesting realization came to me. One is that CBME is really aspirational. We are all chasing these ideas of assessment and growth and all this adaptive expertise. But they all think we're doing that already. So the parents were like, "You're doing what now?" Like, "You're surely doing this." And so I do think we have to remember that what we're doing is more than assessment. It is aspirational, and it's expected by the people we're serving. And if they found out what we do now, I could tell you what they said, because I interviewed a bunch of them, and they were really concerned. And then the last thing I'll just say is, it's been cool to see CBME evolve. That back when CBME really started to take hold in the United States in the early 2000s, things like learner well-being and equity were not foregrounded, and now they are. A lot of the discussion today was on assessment burden and how it's not good for well-being. So just recognizing that whatever you build now and starts getting implemented in the years to come, we're going to have different values and new things that become important, and so it's just going to be a continual process. There is not an end goal where we say, we did it. It's always going to be striving forward. So if this conference reconvenes in 10 years and we've implemented a lot of CBME, you're still going to be saying, and now the next thing, and now the next thing, and that's just how we keep getting better and better.
That was called the arrival fallacy.
The arrival fallacy, yeah.
Say more about it? Okay. I thought it was really good when Ben, because we all had our own little debrief before about what we're going to talk about. I think so we were trying to think about things like common themes that came through, but also things that we thought didn't necessarily come up, but that we thought probably should. And I guess I'd be curious about if we polled all of our educational peers in emergency medicine, program directors and residency leadership and stuff, what percentage would say that they're doing CBME? And I actually think it's probably pretty high. I think that people feel like they're doing the milestones, and they feel like they're doing CBME. And so I think in some ways, I'm afraid that I don't like a learning platform particularly, but I feel like people feel like they're already doing it. And so Martin and I were kind of talking about, so what then defines it? And how do you, is there, what's the litmus test that says, yes, we're doing CBME? If we're trying to get the specialty to move, they first have to understand that perhaps they aren't meeting some of the important tenets of CBME, right? And so in the sense of change management, if our goal is to create a movement to really get to this because we believe it's right, what do we do? Like, how do we get the people who aren't here, which are many more than us, to move forward? And I think that's something that's going to be important as we try to move this along.
And so another theme, building on what Sally just said, if you're CBME, it means you've pre-specified the outcome, and the outcome's somehow relevant to our healthcare system. Okay, and the outcome is a person, is an emergency medicine physician with expertise in service of that outcome. And then if you're CBME, you have arranged a sequence and staging and the whole bit that allows each individual to get to that outcome and takes into account their individuality. And so that so the precision education theme within CBME is about individualization, is about accepting that each of our learners is different. Each of our learners, no matter what we think, will come to us with a different set of prior knowledge, a different set of attitudes, a different person, a diversity of lived experiences and the like. And then how do we, and again, this is higher ambition. In the old days of a cookie cutter, you all come in, I don't care who you are, you're going to do our standard program. In a higher ambition sort of thing, I care a lot about who you are to start off with and what the differences are amongst you, and how am I, as the educator, going to leverage and nurture those differences to create a diverse workforce at the end of it. And so that each of those individualized pathways, how will I know if I am CBME? It is that you have respected these individual differences of person, but also individual differences of journey, of rate of learning, of deciding when you're going to have a family, of, kind of a yada, 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 kind of all sorts of things. And so I think another theme from all of our discussions this morning is this balance between being able to look at that individualization and being able to nurture it and support it and bring it across, while, and this is a startling ambition, rolling all of that up so the residency program director can talk across their cohort, and that all of the residency program directors can talk across their discipline and be able to say to the public, an emergency medicine physician trained in North America is at this level, independent of their differences as they came in. And so that, so I think in a certain manner, we have to give ourselves permission to recognize how difficult the ambition is that we've set for ourselves, to respect that individuality right on shift in seeing the patient in room 4, all the way up to having a consensus conference across the nation that, kind of speaks to emergency medicine expertise across data. And so that, so I think, kind of we're in a moment where we're getting better at collecting the data, we're getting better at analyzing it, we're getting better at folding it into decisions in the whole bit. And that CBME, this shift to CBME folds into that quite organically, actually. The fact that it's difficult actually speaks to the fact that it's trying to get at more difficult things. And so that comes with the territory, as opposed to the old way was easy and the new way is hard.
Yeah, and I think in the spirit of individualization, when thinking about assessments, the assessments need to be early on, right? So that you can identify those learners that, need more resources, some need less resources. But I think all of the educators in the room know, right? It's those percentage of learners that need more support that take up a lot of time and a lot of resources. So having that structure in place, having those resources collated, and I think we can come together as a group. I think we have resources now, but to really build that pool of resources so that, it's less of a resource burden, but it's going to be a time burden. I don't like to use that word, but it is, right? It's gonna take time to get those trainees that are struggling where they need to be.
Yeah, if we're going to keep going in sequence, yeah. But I've got an example to build off of that, which is, I'm part of an AMA reimagining residency project at Mass General Brigham, in which the pathology program moved to CBME, and I'll talk about that a little bit in a while. But we went and we looked at their CCC processes, and their CCC processes were that they had CCC meetings twice a year, and at each of those meetings they talked about the one trainee for who was having trouble the whole meeting, and went through on this poor person and went through them in detail and finished off the meeting, and everybody else passed. And so when they converted to CBME, they still had to do that, but now they had to think about every single trainee and have a discussion about every single trainee at the CCC. And so that meant 4 or 5 CCC meetings a year where there used to be 2. And so again, that sampling rate frequency and that consideration of the data as it came forward, and the thinking about each person as an individual and where they are on their CBME journey, ends up being that higher ambition part of it, whereas the CCC process that we looked at earlier in which they talked about one trainee twice a year, you know, kind of the probably right-sized for that one trainee, but treating everybody else as a no news is good news glom that gets passed all by itself. Right? And now we have data on each one of those individuals. We have data on their journeys. We have fine-grained, you know, kind of whether it's milestones or whatever we argue about in terms of the assessments. But we can do that in a way that, that exactly individualizes, but it's expensive. It's hard, it's difficult as we go forward. And so it's for us to justify and figure out, you know, what size of educational burden we're willing to take on in service of achieving that aspirational competency level that Ben talked about earlier.
Okay, like just switching a little bit. I think over lunch, I asked our Canadian friends, I think we're all concerned about, like, if we go to CBME, how many people are going to actually extend, right? Because often the time variable conversation that Martin ends up having is who's going to finish early. And I think we do need to think about it. And I guess one of the lessons I learned just in conversation was, you know, if we can truly have good analytics, we can good analytics and data, we can have information early about remediation, and then we can place them on a remediation pathway. And so hopefully we will not have to extend that many more people, because I think that's everybody's concern about CBME is, you know, sure, everybody loves to talk about the ones who are going to finish early, but what about the ones that have to go longer? And I think that we need to remember that there is this balance that yes, some of them may need to go longer, but if we're very intentional about our assessment and our training and our remediation and our growth, then hopefully not too many of them will need to do that.
Why don't we just make it 4 years for everybody?
Okay, thank you, Martin. So I'm just saying, we had this conversation beforehand. There's a couple of elephants in the room, and one of the elephants in the room is the 3 versus 4 year. And so why don't we just make it 4 years? I think it is clearly part of the conversation about competency-based education, right? Is that if indeed there is an expertise that says 3 years is not enough and it needs to be more than that, then there might need to be deference to expertise if that's truly the expertise that's there. But it is a competency-based conversation. I also think the other thing we're not talking about is the ABEM new exam, which is a better competency exam, right? It's trying to get to some of the competencies that matter in our field. And so I think that's when Ben says, y'all are actually doing something in emergency medicine. We are doing things in emergency medicine, and we're trying to do the right thing to get better physicians as we go forward. Do you want to say anything else about 3 versus 4? Okay.
I'm not touching that.
It's your turn to talk about something. No, we're leaving that. We're just going to leave that and go.
You're going to leave that?
Yes, we're leaving it.
Okay. I was just going to express gratitude to our Canadian friends. That was one of the best talks I've heard in a while on this, and I think the reason why I loved it was just oozing with humility and curiosity about when you spend a lot of time and effort to implement something, and then you have to learn from it, partially in terms of getting critical feedback. Like, that's how you handle it. You go in with curiosity, you get the people you're serving to the table and learn, and then you respond and make it better. And that's going to happen to all of us, not just EM. It's going to happen in every single specialty that does this or anything else. And I just really appreciated it, and it was cool. And I told them after their talk they should be talking to every alphabet soup organization and every specialty board in the US who's trying to do this, because there's so much wisdom there, and I love how y'all presented it, and I learned a ton. So yeah, I really like that. Thank you, guys.
Well, no, that's it. That was exactly the point. Because I asked Adele that. I was like, so how many of them actually do have to stay longer, right? And it's actually pretty rare. But it also sounds like they have a very intentional remediation period, and there's some penalties in terms of people have to pay if people have to stay longer. And so therefore, et cetera, the programs. But I also think, just back to the 3-4, even though we weren't going to go there, it really does offer us as a specialty the opportunity to do promotion in place, which Martin will talk about next. But it's the sense of, if somebody is really done at 3.5 years, I would like to challenge the board that perhaps if we truly do competency-based education, they should be able to graduate and go out into practice if they want to at 3.5. Like let's perhaps use this 3 versus 4 to allow ourselves to think about time variable because we've got robust assessments. And so can we do a promotion in places which would be where they would be an attending and be able to bill and all that kind of stuff? Or do we really try to get to maybe people do finish in 3 months early or do something during that last period of time. But I think this 3 versus 4 is the opportunity to say we really are going to try and do competency-based education, and we will then manage the consequences of that, which means that people might finish early or late.
Holly or Nicole, how long do we go? Yeah.
4 minutes.
4 minutes. Should we get comments from the crowd then for our 4 minutes that we have left? Or?
We were talking about feedback, and everybody sort of like struggles with that. Okay. What you mentioned about feedback, faculty hate giving feedback. Like several years back, I got recruited to help start a program at a community hospital where everyone else who got sort of promoted to faculty were folks who didn't have like an academic background. And so it was really a lot of work and a lot of culture change and still ongoing. But what happens is, I feel like one of our successes was we had like one guy who was like really into it, and he just decided, and he kind of just set the expectations with the residents, like every day at the end of shift, just prepare to stay a little bit late potentially. We're gonna do some feedback, and it just became just like, this is just like the expectation. He asked them, what do you think went well? What do you think didn't go well? And they talk it through, and then here's my feedback for you. And what happened is then they started to really like it. They started to like look forward to that moment with Blake at the end of, this person at the end of the shift. And then they started asking other people, hey, can you do what Blake does? And started asking people for feedback, and then people started generating the conversation. I think sometimes just changing a little bit of expectation can be helpful. And then, what I do, or I find like it's really hectic at the end of shift. I can't like just try to, you wind up just like doing some crappy feedback at the end of shift because everybody like wants to leave. We're doing sign out. It's too much stuff. So I started just having them write a couple of things down of like what they learned on shift. If it's something that they were intentionally looking up, it was something that we talked about, it was something that they made a mistake about, whatever it is, like it's a part of learning, it's a part of growth. Write 2 things down. In the middle of the shift, we're gonna carve out some time and we're gonna talk about, whether you're a student, whether you're a resident, whether you're a fellow, whoever's in our team working in the pod that day, we're gonna talk about what we learned. And it's not, termed feedback, but it is feedback, right? When we talk about it. So I don't know if that's something that would be helpful, like with your faculty. Sometimes just changing the terminology or the expectation to be, it's like helpful.
It's a culture change, and you shifted your culture, so yeah,
well,
that's great.
slowly.
Thank you.
You Blake someone.
Just to add on to that, it's been our experience as well that in departments where implementation has gone well, there have been invariably what we call champions of CBME, to kind of like Blake, who were able to infect those around them and get them on board. And then slowly but surely, that culture change happens. But it starts with like 1, 2 champions who are able to kind of role model that for everybody and change expectations. The other comment that I had was about like remediation and the idea of extending time variable training. I think a lot of the hesitation, the apprehension and fear around that is that it's going to be some sort of breaking bad news scenario at the end of training where everybody else is getting, like their diploma. Like, sorry, you're not. But the message I want to get across is in CBME, remediation and extended training should never come as a surprise to that individual. It should be a really deliberate process that starts as early as possible. And if the system is functioning the way it's supposed to, you should be able to identify those struggling learners like really early on.
One thing I would point out is that the Royal College has, within their rollout, ended up with funded CBME champions at, you'll correct me if I'm wrong, but at each institution. And so that, so a deliberate part of the rollout of the process was to identify champions and that they were, to use Dr. On's term, to infect those around them with the CBME virus. With an R.0.
Hi, everybody. Mary Tansky at OHSU. So one of the things I wanted to comment on to the previous comment is that our words matter. And I think it's really important that we move away from saying the burden. Because I feel like when we use burden, it automatically makes people feel like we're asking them to do something totally different. Like we've always asked for evaluations. We just weren't really getting the ones that we wanted or the quality that we wanted. People weren't getting the feedback that they were supposed to be getting, because residents are supposed to ask for feedback too. So every time I hear burden, I kind of like have palpitations and shiver a little bit, because I think we should probably think about how we communicate the ask as opposed to just saying the word burden. So more of a comment, but.
No. The sites where the burden is experienced as way more assessment. For us, in emergency medicine, it's not, the burden hasn't come from way more assessment, a bit more, but it's come in a different way around acquiring the right kinds of assessment and these kind of things. So if that burden can be changed to a different term and assessment processes become coaching opportunities and stuff, all of a sudden the burden feeling is lifted regardless of the volume, regardless of the amount. Because the burden in this case, where we experience it negatively, is not because of volume, it's because of the nature and the pressures associated with acquiring certain ones. And so if it can be coaching, if it can be not pressured to gain things in a certain way, it can be all of a sudden a positive and less a burden.
All right, final word to Ben.
I was just going to say, I both appreciate that comment, and I do think there is value in echoing what people tell us. And I think what Yusang's research and others have said is that is what people feel it is. And sometimes it brings you ethos to acknowledge what I'm hearing you say is this is a burden, rather than saying it's not really burden, it's more opportunity. Even if there's truth to that, you have to be careful. We've all had that happen to us, where what we're saying is actually echoed back to us as something that's rose-colored. And I'm not saying that's what we are trying to do, but there is a balance between honoring what people tell you they're experiencing and trying to find ways to improve. And as you're doing that improvement process, reframe.
All right, thank y'all. Oh, you could leave maybe 3 of those or not. All right, Sim, Jeremy, and Meg. So we're going to talk about adaptive expertise in coaching, and I am going to pass it off to, Meg, Jeremy, Sim.
I was like, where is it?
Just Meg.
I want to say that my rider included an actual fireplace, and it is not here.
I know, and also a sofa. It said sofa style.
And many only green M&Ms.
Hi, everybody. Maybe let's just do introductions real quick. So I'm Meg Wolf. I'm at the University of Michigan. I run our coaching program there, and I do pediatric emergency medicine clinically.
My name is Jeremy Branzetti. We spoke before. I am a faculty at Yale. My interests lay at this point in both on the learning how to learn adaptive expertise side, but also the coaching as a developmental tool side.
And I'm Sim Mand. I'm from the University of Wisconsin. I am the director of our resident coaching program. So was very heavily involved in the development and implementation for that. Cool. Should we just get started? All right. So Meg, so we're just going to kind of simulate a couch sofa style talk and just get started with some questions. So kick your feet up. So Meg, I'm curious, what would the ideal coaching model achieve in your opinion?
It's a good question. So maybe before I dive into that, we'll just sort of talk about like what we mean by coaching, because we've had a lot of conversations today that have used that. And I think what we heard this morning and what I think we sort of think of coaching is two different things. One is the sort of longitudinal coaching, where a learner is working with somebody over time in a very intentional way that might include portfolio review, may or may not include direct observation, but really the underlying thing is that they are working on that learner's development over time and helping them identify gaps and helping them develop goals and action plans. So really helping them practice and learn informed self-assessment so that they can ultimately do it on their own. The second thing that we mean by coaching is what we heard from the Canadian folks, that's sort of coaching in the moment. It doesn't necessarily need to be married with that kind of assessment piece. And in fact, I think when we were sort of conceptualizing it, it wasn't actually married to that assessment piece, but really just more these sort of on-the-fly conversations that you're having with faculty, and hopefully all of the faculty are able to do it so that they're getting these robust coaching conversations multiple times through every single shift, where it's really like somebody watched somebody do something. So, I watched somebody have an interaction with a nurse, and we immediately talk about it, the good, the bad, the ugly. Obviously, this isn't happening with every single interaction of all shift. You wouldn't get anything done. But, multiple times throughout a shift, you're getting kind of this sort of reflection opportunities throughout the shift. And paired with that, it's not just the feedback, but it's really helping that learner identify what they think they could have done better and what they did well, and then helping them from there develop an action plan of what they want to do differently. So I think with those two frames in mind, Sim, to get back to your initial question, I think it's a variety of outcomes of what that kind of ideal setting could look like. So one is really helping the learner develop those informed self-assessment skills so that they can not just graduate with competence, but that they can be competent, yes, but that they can continue to learn as they go on. They continue to reflect. They continue to identify those gaps. So we don't have that, Ben, you said that the escalator thing down. I've never heard that before, but I loved that. What was it called? It was lovely. Downward escalator of competence. Yes, downward escalator of competence. So we want to avoid that. And I think yes. Seizure, coma, death, bad. So, I think coaching might be one of the keys to sort of helping all learners develop that skill. And then perhaps that coaching in the moment, that's really more about that competency attainment and that skill attainment and hopefully mastery for some. What do you guys have to add to that?
I think I'm probably just going to be echoing onto those points, but when you distill that down, there is the points of competency. It's like, if I'm performing X and it's not to a standard, or you're able to observe and give me some useful feedback, we discuss ways that I could do that, what my plan might be, et cetera, the usual coaching conversation components. Great, you've helped achieve the competency part. I think the other part, which is what's really going to matter after practice, is, okay, what is the meta level? How do I think about how I approach this? Could I have approached this better? What am I going to do when I'm on my own? What would I do in this different circumstance? So in that coaching to the metacognitive part, how do I approach this to be better, rather than a specific, if I do X next time, I'll be better. And one of my many, I guess, rants is about the concept that we really do not engender this learning how to learn part. We say we want to. There's some great work out of Canada with what's her name? Mylopoulos, thank you, right? And many other people there on this entire concept of preparing for the learning you're going to have to do in a future that you're not doing right now, which is a kind of a heady concept to grab onto, but there's an entirely separate skill set here. And I think this is where coaching can really do that, because it's not about a unit of knowledge to get into someone's brain. It's more about an approach system, which then will allow them apply that system in a different and novel space at a later time.
And I would say echo and agree with all of that. I would say just with our experience at our single site with implementing a coaching program, longitudinal coaching program, for our residents, that many of them, if not all of them, don't know how to do this. Like even in medical school, we don't really teach them how they best learn or how to think about learning. And so a lot of the initial steps with coaching in the moment or longitudinal coaching relationships is almost walking them through the process themselves, right? So I think a lot of this is heavily faculty or coach driven, just to help them get into the process of, okay, what are you thinking? How did you perceive that? Did you identify any gaps? Maybe you didn't this time, but let's walk through that and kind of walk them through the entire process so that over time with multiple iterations that they can start to develop these skills on their own. And so that's really the goal that we have had, at least, introducing coaching concepts with our learners.
Yes, Tim, I think that's a really good point. Like, I think of it as sort of like you start with the training wheels on and like you're really directing the process as a coach. Yeah, you're structuring it. You're really walking them through, like even down to the level of like, this is how you approach feedback. This is how you process it. Like, let's unpack that. Let's get rid of it. Like, let's do what we need to with this emotional response, and then let's get down to the details of it. Think about the themes and sort of move on from there. So I really like your analogy of that. As we're talking about this, so we're like talking about the beautiful potential benefits of it. Ideal state. We heard a lot from our Canadian friends this morning about some of the challenges. And I know we've sort of thought a bit about this too. Jeremy, do you want to kind of expand maybe a little bit on what some of the challenges are that we are dealing with?
Absolutely. I think, I mean, look, one of the great lessons, and I want to echo what Ben was saying about approaching with curiosity and humility to look at a process and what are the consequences, unintended or positive, beneficial, otherwise, and say, great, now what do we do? And iterate and change the way we should all be doing in a cycle like that. So one, that was very informative to our group to start thinking of like, ooh, we really made sure that I think it swayed heavily our subgroup to ensure that we have dedicated and focused study on the learner's perspective, right? It be between their experience, not even just what they do and how they assess it, or are they, whatever you want to call successful as an external measure, but as an internal one. Like, are they interpreting this in a way that is value added and positive and helping them grow, and something where they look at it and say, yeah, that was a real big part of my residency. I would love for that coaching program to be a part of that. And actually, even just a brief point of going back, one of the things here in terms of what can we do to get them set up, as I've gone through the course of my career as an educator, though my one, like, what would I forgot what the challenge was of what would be one of the takeaways is, like, show, don't tell, right? So when was the last time any of us as an educator went and described a process of understanding what my gap is, I'm going to describe to you how I'm going to go about this, and demonstrated an approach that is formative and coach-based to a learner so they can see what they will be doing later when we're in that position, right? It's not that we're hiding it, but it's just not out there. So it's a little bit of, we're doing this study with my colleagues at Yale. We're trying to understand why residents struggle with goal setting, and it unintentionally seems performative to them. Like, I've gone to them, like, what's your goal? And if they don't have a right answer, then it's a bad experience, right? And so, like, I freeze up and don't want to do it. And nobody would have expected that. So unintended consequences, I think, are a big part. I think one of the other big takeaways, which I think is a microcosm of the experience, was the difference of, you want to be able to give guidelines to how to do good coaching without being prescriptive in a way where you can't actually make that program happen, right? So, like, I'm in the, like, outside of learner coaching. I'm like professional coach, right? I went and paid money to go do this. It's not cheap. It takes time. It's a lot of hours. There's just simply not enough resources to take all of our faculty and send them through that. And if we were to go and say, great, we're setting a really high bar, we expect everybody to do this, it's not feasible. So you don't want to be that level of, it must be this one way. Yet at the same time, we really want to make sure everybody's understanding what are the core skills and capabilities of what you can do with coaching. So if it's just we're going to make Blake live forever. If it's just Blake who is at the end of shift and has probably never been taught coaching in his, maybe as, I don't know, but just has the care to be like, I'm curious about what you thought. Like that curiosity and humility of someone else and like, wow, that's cool, I'll learn about that too. What are you gonna learn about? Right? You don't feel threatened about that. It's the subtlety in delivery, and you don't need to have a 10-step coaching program or follow something, one of the many published ways of doing this. So I think trying to communicate, the real challenge is getting the underlying value of coaching and understanding the many ways people can do it without having to be too prescriptive or paint by numbers in a way that then limits either the program's ability to implement it or the person's ability to learn enough to follow it. Those were kind of the real big ones that stood out. And then, another, I think, big category, or if you guys want to chime in, was essentially what is the competency? What is the training of the coach? What do they need to know? And it has that same problem. How much do you need to teach and make sure everybody does? And how much does it get across the core points and let people cook in that area where they know how to do that well, whether it's post-shift feedback or whether it's the long-term goal setting. I don't enjoy as much the post-shift feedback conversations. I love to sit and iterate and like, okay, let's talk about the big picture things. Okay, that was a goal. Let's see how we can shape that better. Why is that a goal for you? Like really sit and talk when I had that chance in program leadership. Everybody can take everybody can go through the form that they like, but you really want to be able to advance the coaching in that way, in a way that you're good at, and make sure that others feel empowered to do that too.
I was going to say, I just want to echo a point that Jeremy made of we are all medical educators in this room, but that coaching is a very discrete skill set, just learning more about relational or communicational skills that varies. It's different than our other academic roles of being educators and mentors. And so I think I do want to emphasize that it is a discrete skill set, but that it is something that is very much feasible and within our wheelhouse to learn, and that there are plenty of different resources out there. There's no one right or wrong way of doing it. There's a ton of resources to learn just even how to get in that coaching mindset, and I think distilling it down to just being curious about the learner in front of you, right? Seeing them as a human being, not reflecting an agenda on them, not being judgmental, trying to put aside the hierarchy, but just being curious about how are you reflecting on things? How are you perceiving things? What are your goals? What are your motivations? What are some things that we can connect on and make this a collaborative process and partner on and really build upon and help you grow and develop and move forward? And again, there's a lot of ways to do it. There's a lot of resources. There's the AMA videos. There's plenty of coaching guides. A couple of different models from the literature that I personally like using are the ADAPT model, which helps for in-the-moment coaching around feedback, and then also the R2C2 model, which just, again, gives you a framework of if you're nervous about this or you're not really sure where to start, it just gives you a framework of how to approach a dialogue with a learner and how to even approach that conversation. There's so many other ones out there. I think that our Canadian colleagues just came out with one as well. But there's so many resources out there if you're interested in learning more about it.
And I would say briefly, one, it's unlikely that one is going to be proven better than the other. It's know how to apply it and do it well. I would say the other thing that's a real challenge, going back to the idea of being curious, is especially all of us as physicians or working in the healthcare space, to turn off your diagnosis ability and stop trying to know the answer of the person who's telling you oh, their problem is this, or oh, this is what the issue is. There may be times when people haven't reached competency, you can say, you haven't done this thing, and there is this gap, and then that's at least a diagnosis of this is objective, and it's really more assessment. But instead of thinking you know better, just taking the approach of man, I wonder what's going on. Hey, what's going on? And really having that mindset goes a long way and is hard for all of us to do.
Yeah, I think if we can just all sort of embrace using coaching skills and not worry so much about the big C coaching, that would probably get us a long way. We did a couple years ago do a lot of intense faculty development using R2C2, the in-the-moment model in our division of PEM, to try to help build some adaptive expertise and informed self-assessment skills in our fellows. And it was really interesting the ratings of that the trainees gave, the feedback they was receiving went way up. But when we sort of saw what the faculty were doing a year later, it was not R2C2, And so is really interesting, kind of to your point of like, we don't need to be so prescriptive. Like, it was helpful, I think, for them to go through that development process and sort of like get in that mindset of being curious and like really not being like, this is what you did wrong, but really sort of like a dialogue about it. We still had the intended effect, I think. So,
So I get towards that end, we want to make sure that we maintain good time here. So Sim, you recently just published a couple of articles. We're part of a team and a number of other people here are involved. Maybe we can end on telling us a little bit about, okay, what are the practical good tips? What are the things that you are, if we don't have a best practice, what's our best perspective on that? Or what may have been shown, like the best ways to go about if folks are interested in either a coaching approach or setting up a coaching program in their own institution to fit in a competency model?
Oh, wow, Jeremy, what a question. I think there, again, I'm going back to, I don't think there's a right way to do it, right? I think there's going to be a different model and a different approach that works for the learners at each institution, honestly. I think a big part of what we're learning through this coaching consensus conference is really recognizing what competencies, like what are the bare minimum competencies that coaches need as faculty members and how to train them. But I do get back to the point of what Meg made earlier of, as we develop our faculty, I'm not sure that they're also being super consistent with how they're implementing what they learned from our coaching curriculum in their interactions with residents. But even being there, open, curious, and really just being a safe space for residents to reflect in or even voice concerns that they have has been huge in terms of just that culture shift of, we are faculty that are invested in your development, and we're here as a partner for you to grow and develop throughout your training. And even that culture shift and that perspective and mind shift has been huge with our learners. So again, I don't know if there's a right or wrong way to do it. I'm hoping that'll be part of what we research and what we learn more about. But it's more of that culture shift, that mindset of just being present with the learner.
Have either of you or anybody in the audience contribute to this on this tension of, are they there to help me grow or are they there to assess me? Meaning, can you separate church and state of assessment and formative growth? Given the limited resources we all have with faculty, right? They're gonna have to do multiple hats. Any?
Well, so I run our coaching program for the medical school, and there we've been like very clear that the coaches are never in an assessing role for their students. In the GME space, we just don't have that luxury because you're never not going to work with the people in your department. I have seen some programs do this where they have longitudinal coaches in other specialties, and they like trade. So that is one way. There's some sort of emergency outside. I will say that I think the learners seem to buy in more when there is that content expertise. And so I don't know, for GME, I really feel like there's real value in that coach being somebody in emergency medicine, somebody in our field. So there's already that like shared understanding and experience. And maybe it'd be different if we were talking about like well-being coaching or something like that, or even just simple leadership skill development coaching, something like that. But I think that this sort of CBME coaching is different. Sim, I don't know what you...
Yeah. I was going to say, interestingly enough, we just finished some focus groups with our residents. We're finishing up our second year of our longitudinal coaching program. And it was variable in terms of residents who actually wanted to work with their coaches and who had not been able to do so, as they viewed them as a credible source for feedback to come through. And so some residents voiced that, hey, I didn't get a chance to work with my coach, and I really wish I had, that there was no pressure of, I felt like I was being evaluated. It was more of, I knew my coach was there to really help me along. And then there were definitely residents who worked with their coach and maybe felt like there was that tension still of they're my evaluator, but they also say they're here in my corner to just, help me grow and develop. And so I don't know if we've found the right answer yet for that. And I suspect each learner, just depending on how they incorporate and internalize feedback and whether or not they view the coach as a trusted and credible source. It might just vary based on learner to learner and based on the coaching relationship.
Holly, how are we doing on time? 5 minutes. Okay. I think this is a great time. Does anybody have anything they'd like to chime in with their experience, either on this issue of the two hats of assessment and formative assistance, or even on just the broader sense of experiences, questions, conflicts, open ways about coaching? Cooney, you're up.
So as I reflect on kind of coaching in environments outside of medicine, I often look at the professional sports role, and you see how every team has multiple coaches for the multiple roles. And kind of picking on Holly with her Moneyball example in the literature a couple months back, right? Like, do you feel like we need to go to a model where maybe we're not coaching the whole model, but we each have a niche that we are responsible for our learners, and that kind of separates that whole tension between performance and evaluation, because I'm coaching for the performance in one field, but maybe evaluating on the others.
Yeah. Thoughts? Yeah.
Yeah, I do really like that approach. I think that if there was sort of an ideal thing, it would be that there is an overarching longitudinal coach and that you have these sort of, position coaches for the various things. Like maybe there's somebody who is like watching you and your communication skills, and there's somebody who's helping you with procedural skills, and there's somebody, so like really, logistically that would be challenging. And so, it would be wonderful though if the majority of our faculty were comfortable with like a core set of in the moment coaching skills, so that they could all sort of wear those different position hats as the needs arose. So I love your analogy. Thank you.
So I have a follow-up question to your question, and I think it pertains to the residents who are kind of the ones that folks are like, that one's struggling. How should we give advice to the folks that are responsible for coaching those residents who are generally aware that their resident coachee is struggling? What kind of specific advice might we have for them?
So this is always going to be difficult, because now there is an external determinant on the outcome of the coaching versus what should be just like you, me, and you as the learner ultimately make that choice. And through my coaching, maybe I'll make sure I can, if there's learner coaching, shape around the edges to make it a more positive experience or more likely to be functional. In the remediation sense, there's an external outcome that has to be satisfied, and that is always going to make that harder. I think there's probably two layers to my answer, and this is just pure opinion, I can't speak from a large experience. One is the opportunity at the beginning of training to try and set the culture of this is going to be like, we all have the room to grow. This is a thing that will be, even if it happens to you, this is about making you better, and like that environment will go a long way. That being said, that's already passed at the time of this discussion. I think the next part of that is just real upfront, open honesty, where you engage in this, like what would be the coaching engagement, and say, look, I'm here to help you find a way to get to this thing, right? How you want to get there, how we talk about that, that's back in our power, your power as a learner, but this is going to have to be done. And then it would just be talking to try and empower them to choose the best path, but still has the same an outcome that's been functionally predetermined for them.
I was going to say, I agree with that. I think many, at least, and we kind of talked about this over the course of our discussion, but many learners want to improve. So I think having some external feedback of even presenting as, hey, this is a piece of feedback that you've received. How do you feel about it? What are your perceptions about it? Is it a surprise? And then once that emotional reaction is over, how do you move forward? I think the toughest part, and I don't have the answer for this, but the toughest part is the learners who maybe don't have the insight or they're not willing to accept that feedback. I have not solved that challenge, but if anybody else in the room has, please come talk to me afterwards. But I think that's the hardest learner to engage, are those that are not either willing to take any external feedback, or it's completely in contrast with how they perceive themselves doing, that it's really hard to engage them in that coaching conversation. But for the most part, I would say, even if it's a surprise piece of feedback that's external to that relationship, they're still willing to at least interact with it, see how they feel about it, at least in my short-lived experience with coaching.
Okay, time for more? I waited till you put food in your mouth before I asked. Any other questions? Oh, there we go.
I think just to add on to what Sim just said, one thing that we've been trying is kind of like an introspection prompt, is what we call it, I guess, where at the beginning of the rotation, or even at the beginning of any of their PEDD or any kind of rotation, that they set a goal for themselves, and it doesn't have to be, as you'd mentioned, like, just it doesn't have to be right at a level of you tell me what your goal is right now. You can just write it down. They can write it down. They can kind of go through that process of introspecting a way to figure out where their goals or when they want to achieve those goals, and have the check-in process with their coach, and so whoever that process. I'm not sure if that's something that y'all are trying or have tried, and if that's something that you think might work.
Yeah, definitely. So it sounds like the preparation, it sounds like what you're using is almost the prepare to adapt model of preparing at the beginning of shift of what are some things you want to work on, what are some goals that you have for yourself, and then continuing to check in after performing some direct observations throughout the shift. So I think that is something that I use on shift, and it works wonderfully. Again, there are the residents who maybe have some struggle a little bit with those expectations up front. And so it just goes back to, you might need to walk them through it a little bit more diligently. And as they continue to get exposed to that model and coaching on shift, they'll kind of hopefully develop those skills and self-directed learning as they go.
One last follow-up point.
I think you've highlighted really nicely the breadth of opportunity around, there's lots of models for coaching to look at. One of the things I'm less familiar with, but I think has become very important for us to consider is resources for faculty for just-in-time teaching around coaching. And what I mean by that is I don't know that we really have a good way to empower our well-meaning faculty who feel undergunned to do what they're about to do in terms of feedback, and something to provide them with some kind of like 1 minute accessible educational activity. And I haven't seen it yet, if anyone else has, but something that can be used in the moments when a well-meaning faculty who doesn't really feel ready to do something can access it. And we do this in clinical stuff all the time, but I think, and we do, coaching modules for our faculty. I do them in my own faculty all the time, but it feels a little malaligned as opposed to when faculty really need it, which might be either in the moment or when they're struggling. So I wonder if you have any ideas about that. Maybe that's opening a big can of worms, or if this is also something that you think would be useful, or if it exists already that you've seen.
Just for clarity, do you mean in the moment content-based thing that they can both have a shared content discussion, or how do you frame a discussion of very quick, like?
Yeah, what I mean is I think it's hard for faculty to say, oh yeah, like 3 years ago I did that coaching course, and I guess there was a model that I had, but today's the day that I feel like I really need to do something well for this trainee who I'm struggling to figure out what to do with. And if there's things you're aware of that we can give to our faculty to use in the moment if they're so interested.
I mean, I was going to say, I don't have a in the moment card of like, this is a coaching conversation, like,
Yeah, R2C2 does have some readily available free things like online that you can download, like one-pagers or little handouts. I think they're really helpful when they've already done training in that specific model. Yeah. That still is like a, 10-minute thing to engage with. Yeah. So a like emergency medicine focused, this is like your like one, not even a one-pager, little thing would actually be really valuable.
Yeah.
Someone should do that.
Exactly.
All right. Thanks, guys. Chairs can go. All right. We are getting into our last talk of the day. We're going to talk a little bit about precision education to operationalize CBME. And Martin, you are up first.
Okay, I'm going to do the high wire act of trying to relate what I learned in working with pathologists to us. I think it can be done. I'm not sure, but we're going to find out. Pediatric emergency doctor. I moved to Boston and team up with some great people at Mass General Brigham. And we wrote a grant, and John Andrews is in the room yawning right now, but he's here ostensibly representing the AMA in their GME efforts, and they put their money where their mouth was in the sense of funding 8 projects for $1.8 million each and the like, and 10 to something, I got my math wrong, but lots of money in the GME space. And so Mass General Brigham got one of those grants, and we were going to do, or we did, competency-based time variable training. And what that looked like was, at the time that we solicited Dr. Andrews, we said 10 residency programs will convert to competency-based time variable training. And then we got the money, and then a few of them stepped aside for kind of various philosophical reasons. And that's its own story that I'm not going to get into, but the gist of it was we got out of the 10, emergency medicine was one of them, and they fell away because they had a few citations or regular ways of doing business that sucked up their innovation bandwidth. And one of the things we learned was in GME just how little innovation bandwidth there is, and anything can, kind of a residency, the champion moves to another institution and you're done, and that sort of brittleness to the innovation. But anyway, we got 3 programs up to the boards, and then the boards allowed one of the programs to go through, and that's the pathology program. And so that the pathology program had a really, really good assessment system, and so that so the American Board of Pathology said we could do this. And so what I'd like to do is compare 3 ways of finishing residency and going into independent practice. And that pathology example is this Model 3 sheltered independence, where what happens is that we graduate you when we graduate you, so that a few months early, a year early, or whatever it is in a 3-year program, and then you become a fully credentialed board eligible attending in the institution. And so that's the ambition there. And so so what we're talking about here is, you do your initial training, and that green dot is residency, and the blue bar is your first year of practice. And what we're really paying attention to is that transition from residency to practice. And and the words that came into play here are certification, can you be an attending? And so that, are you an emergency medicine doc? Pretending, the idea of simulating being an attending and bringing it across, and then this notion of a sheltered independence, that within your institution you're an attending, and what that really focuses on this transition. And so the 3 models that we look at are, kind of that top one there is the pretending model, in which you're independent within your initial training. The plastic surgeons and orthopedic surgeons reach into your practice and do a practice biopsy actually in practice, and pull back your cases and won't let you do your oral exam until they have a sense of how you functioned in practice, and then the sheltered independence model there. And to kind of summarize across those, here's a couple of learners, and a couple of learners who start with a different y-intercept in terms of how good they are at a given competency, and then their different paths as they go along. And what I've drawn there is a competency threshold and an excellence threshold. And so these people are individuals, and individuals go through this in different ways. And so I've mocked this up as them crossing the competency threshold at different times. And in a time-based system, this is what that looks like. They each finish at the same time. And so this is what we mean by time constant competency variable systems, in that everybody finishes at the same time, but at different levels of competence. And so that in a competency-based type of thing, we all argue about what the competency threshold is, but then, kind of the idea is one might finish early, one might finish later, but they both get to that threshold, and we can make a claim as to that threshold. And so the thing that we learned in this sheltered independence model, where we wondered about those transitions, was that there is an implicit dividend that gets spent somehow within the system. And the thing that we learned is that if you think your system is not time variable, I would claim that it is. And that the time variability, that dividend, comes out of the skin of the resident right now and allows you the convenience of graduating everybody at the same time. Whereas if your assessment system is able to determine where each person crosses, then you can have a discussion about how you're going to spend that dividend. And so that it may well be that you use that dividend to go across and, across and use it to pursue excellence goals. And so that learner one there, if they as they cross, if they stay in the system, they use their time to pursue an excellence goal. Or they may choose, after crossing, to go do research, because that's going to be their role, that's going to be their identity, and they've decided to be a researcher or thing along those lines. But what I'd like to do is then go into, kind of how that dividend can be spent. And I'd like to make the argument that I'm going to show you a couple of use cases, but that those use cases are, kind of give you a sense of acid test competency-based systems. And so, kind of perhaps if I was able to change my slides at the last minute, I would call this the South Korean retrainee, kind of as you go across. And so you heard earlier about how Dr. Ahn was let off a year early for good behavior. And so that when we presented the grant, one of the use cases was an Australian who had finished emergency medicine residency training in Australia and then presented to our residency program because our board said they had to. And so that it's that person's y-intercept is way up there, right, in terms of them entering the program. And they're going to cross that competency threshold early, and so that dividend ends up accruing to the program, that you've got this hyper-competent board resident who's putting in their time, is not let off for good behavior, and is contributing to the system in a way that one might perceive as being unfair. And so that the other example we presented was family leave. And so that the notion of time minimums, and so that somebody goes off on parental leave who comes back, who has met all of their competency thresholds, but then has to do July and August to pay back their parental leave, is now off cycle in terms of fellowship applications or jobs and the whole bit, pays a tremendous penalty for that parental leave. And so again, you can argue about the fairness of this and call schedules and all of that kind of stuff, but a dividend is accruing to somebody here, and that dividend being spent on parental leave might be a good argument for the wellness of your program in terms of social benefits to the pool of physicians as they go across. And so that pathology program that I was telling you about, the way we spent the dividend was to say that being an attending is different. And that when you graduate from residency and you are alone in the emergency department, or as alone as you're going to be, and you're signing the charts, that feeling at the level of your adrenals is different. But doing that in the residency program, where you know the nurses' names, you know who you can call, you know where the bathroom is, you know kind of the yada yada yada, that becomes, instead of out of sight, out of mind, that particular part of your development, you've brought it back in-house, and you can feel the degree to which the person is functioning as an attending that is credentialed, and that is signing the people out alone in the way that they're going to ultimately. And so it becomes an educated, so that first year of practice or those first months of practice become an educational target that we can then coach the person up on, and this is what it's going to feel like when you're truly out there in the thing. And so we can, we can argue about pretending versus really attending, and, kind of how much benefit there is of going through the rigmarole of certifying them when you could just walk off the ward and have coffee while your third-year resident is doing their thing. But emergency medicine in particular is really, really well set up to this kind of sheltered independence where the educational target is the notion of being fully accountable for the patient care as they go across. And so this is what we've done with that pathology program, and has worked really, really well in terms of bringing things across. And so in summary, I'm going to argue just to provoke that we are already using time variable approaches, and that time variability is being soaked up by our residents and not our programs. And so that we need to think about these dividends of crossing, for a given performance thing early or late or whatever, and who those dividends accrue to, and how we can creatively use them for good as we go across. And I think there's a positive aspect to this in that the increased sophistication of CBME assessments give us a finer sense of when that person crosses the competency line. And so how are we going to use that better look in order to advocate for spending that dividend well? So thank you.
Brian, I think you're next. Yes? Maybe? Yep. All right. Your guess is as good as mine how this works.
Let's see.
You figure that out. Yeah.
I think so. Okay, thanks. Good afternoon, everyone. My name's Brian Kwan from the Department of Emergency Medicine at UC San Diego, and I appreciate the opportunity to tell you a little bit about some of the work we've been doing in the precision education space with regard to procedure logging. This diagram, it's actually a privilege to be here because one of the authors of I really like this diagram. One of the authors is actually just heard from one of the authors here. Typically in a lot of residency programs, they rely on a residency management software system like MedHub or New Innovations to collate data about duty hours and evaluations and procedures. And we all know that for better or for worse, the true north of what people are actually doing in the course of their clinical care is actually more accurately reflected in the electronic health record. And again, for better or for worse, I should say. So the issue is that historically, these two systems have not really talked well to each other, or in most cases don't talk to each other at all. So one of the things that, in my opinion, makes emergency medicine unique is the number and the breadth of bedside procedures that we're trained to do. And I work at a rural, remote site for a lot of my clinical time, as I'm sure a lot of you do as well. And it's not unusual for the emergency physician to be the only person in the hospital that's capable of doing these procedures. So it's a pretty important part of our training. Now, when residents complete procedures, typically they'll consent the patient. If the patient's consentable, they'll perform the procedure. And then they'll go to the electronic health record to complete whatever procedure documentation they're going to do. In our shop, that's Epic. However, the issue then becomes that, related to the slide we just looked at, that residents are then expected to go to the RMS and essentially to complete or recomplete all the documentation they've already done in the electronic health record. And this is obviously a very wasteful and duplicative workflow that we tried to resolve. So what we did at our shop is we built a system that automatically extracts all procedure completion data from the electronic health record and sends that over to the RMS using an application programming interface or an API. So this includes procedures that have been in the past relatively hard to capture, like medical and trauma resuscitations. We're able to get those. And initially our pilot program was just focused on bedside procedures in the emergency department. We subsequently expanded that to all other departments in the hospital. When the system was deployed, the way we did this is that we initially didn't turn on the transmission to the RMS part of this. We let the system run silently and rather deviously for about a year. And the reason why we did that is we wanted to definitively know if this automated system was doing a better job than what the residents were doing manually. So they're serving, it's the same residents in the same time frame, they're serving as their own controls. And to walk you through this diagram, this is the number of procedures logged or captured by week. The blue dots represent the procedures in each week that the automated system is capturing, and the green dots represent what the same residents in the same time frame are logging manually in MedHub. And the horizontal dotted lines here represent the average number of procedures per week over the course of the study period. And the shaded bars here represent the 95% confidence interval. So the first thing I'll point out is that, not surprisingly, we're capturing about 80% more procedures in the automated system, that a machine is doing a better job with a rote repetitive task than a human is. That's not, in newsflash, water is wet, right? That's not a huge surprise. But the fact that the confidence intervals are basically the same, even though the automated system is capturing 80% more procedures, suggests that the automated system is also capturing not just more procedures, but more consistently. So we're getting a more accurate sense over time of what residents are doing. The other thing I'll draw your attention to is that in the automated, the manual logging, there's a spike in late May. There's another one in early July. Not surprising, right? That's the bookends of the academic year. Then we have this spike over here in the week of February 5th, I think it was. And I asked, which kind of puzzled me, and I asked our program folks, what happened? Was it semi-annuals? Did the residents get a nastygram telling them to remember to log their procedures in MedHub? And the answer was no, but we'll return to that point in a minute. So here what we found is for a selection of procedures comparing the automated and the manual system, again, automated being blue and the manual being green, broken down by PGY. And you see that the second year residents, there tends to be an increase in the number of procedures logged, both automated and manual systems, when we go from 1 to 2. But then we often, in the manually logged procedures, get a huge drop off after the PGY 2 year. And the most logical explanation being that for our folks, at our shop, the residents tend to meet their minimums during their PGY 2 year, and therefore any incentive to continue pursuing this wasteful duplicative workflow is going to evaporate. Now, for medical educators, from our perspective, what that means is that there is a massive amount of procedural experience that is lost. That's just going off into the electronic ether, and we never know about it if we're relying on manually logged data. So this is actually a sort of slight modification of the plot we looked at a minute ago. And what you're seeing here is the manually logged procedures on the top and the automated on the bottom. And this is broken down by PGY. So the blue band are the interns, the green are the 2s, the orange are the 3s, and the red are the 4s. So what you can see, sort of similar to what we just saw a second ago, is that in the manually logged system, the width of the chunk that corresponds to the 3s and 4s is very narrow, because again, once they've hit their minimums, there's really no reason for them to pursue this duplicative workflow. Whereas in the automated system, we get a pretty consistent number of procedures captured by both the 3s and the 4s, despite them having met their minimums. Now, back to the question a minute ago, this week of February 3rd, where did that unusual spike come from, and that explanation? And it's pretty clear from looking at the manual plot that that spike was caused by a PGY4 resident. So I actually tracked this resident down, not tracked him down, but I asked him, what happened? And what he told me was that he was on a bedside ultrasound rotation in the 1 or 2 weeks prior to this, and so he was sitting down and trying to log all the scans that he had done during the 2-week period. Now, I tell you this not to throw this guy under the bus, because I actually know him. He's a really stand-up person. I'm not accusing him of dishonesty. The point here is that this is the behavior that is incentivized by relying on manual workflows. That's the point. Because my APD, now the program director, Dave Wong, is sitting in a room when I was a resident, and I'll tell you, Dave, right now, since you already graduated me, that I did this multiple times when I was a resident as well, so sorry. How do we take data and turn that subsequently into information, knowledge, and dare I say wisdom? It needs to be visualized. It needs to be pushed down to the level of the people who are going to take action on this. So this is just my personal opinion, that the common RMSs in use, the data visualization tools are rudimentary, primitive, perhaps, and so we wanted something that was more functional. So UCSD, the enterprise business intelligence data visualization tool is Tableau. So we built a bunch of Tableau dashboards that pushes data to the people that are actually going to take action on it. So this system, we published this in JAMA Network Open. The QR code will take you to the publication. And in that publication, the supplemental information contains quite a bit of technical detail about how we built this system. And it was written in such a way that make it, the goal is for you to just hand this to your IT or informatics folks and say, this is something we may want to do if you're interested in pursuing that. So if you're interested, please have a look at that. And of course, I'm happy to talk to anyone who is trying to do something similar, wants to do something similar. The last thing I'll leave you with is, this is Kay Lind, who was another one of my attendings in residency, and when we were discussing this project, her comment was that, you know, as an educator, she wants to know what the learners are actually doing during their clinical care, and doesn't care as much about how good they are about going to a website to enter data. And I think this really captures the sort of like why behind this project and the why also behind precision education. So if we say as educators, if we take it as axiomatic that we want to use the most complete, the most valid, the most accurate set of data to make these important decisions about advancing trainees through their training, then I would say that, that at least for procedure logging, that relying on the sort of standard manually log workflow, that's not going to do it. And it kind of behooves us to look for the most accurate source of data to make those decisions.
All right, next up. Oh, no. We're going to let this session run us a little bit long. I swear to you, we're still going to get out of here on time, if not early. You can hold me to that.
All right, my name is Danielle Miller. I'm faculty at the University of Colorado, affiliated with the Denver Health residency program. And I will keep us on time, Holly. This whole session is about like precision and education and how we're operationalizing that. So, right, Martin's talking about time variable approaches. Ryan just talked about sort of automating our procedures. And I'm going to try to talk about our future envisionment for how we're incorporating dashboard data and clinical performance data of residents into dashboards for precision education. So when you think about it, the ACGME requires all of our trainees to reflect on their practice, right? Their clinical practice. This is practice-based learning and improvement. We say, oh, how are we going to make changes? And so this really benefits the learner in addition to the residency program, right? Because we can see how our residents are progressing and potentially assessing them. But how many of your trainees actually get clinical performance feedback or actually clinical performance data? And so this is where dashboards come into play. So when we think about dashboards, they're visual displays of data from which you're making a decision. And these have been modalities that we've been used by clinicians for many years. And so I'm going to just give you an example of how this is what University of Colorado's clinical performance dashboard looks like for our residents. And so you can see here, well, this is just one of our pages. So you can see these are our patient and quality indicators. We actually have 41 metrics at the University of Colorado. They're sort of based on these like 6 categories. So you think about your productivity metrics, like your door to dispo times and patients per hours. We have these patient safety and quality indicators, so you can see like 9-day returns, CLABSI rates, CAUTI rates. We have procedures. We have something called like discordant diagnosis. So if you admit someone for pneumonia and they end up having a pulmonary embolism, maybe you should reflect on that. And so it'll pull those sort of MRNs. And then we have a category called high acuity cases, and that's like stroke alerts, STEM alerts, et cetera. So this is just one of the pages. And so imagine with me like the future of precision education in which you're sitting down at your annual or biannual review with your resident, and you're sort of reflecting on all these clinical performance metrics that are pooling real time from the EHR. And say we're talking about this 9-day discharge, this 9-day return from discharge patients, and you find like we norm ours by percentiles, so 75th and 25th, and it's normed by your class, and maybe you're out of bounds for that. You're like at the 75th percentile. It gives us something to discuss and say, hey, maybe we should reflect on those cases, and we have the MRNs of those cases, and we find like, hey, maybe you keep discharging people with purulent cellulitis, not based on our antibiogram, and you should, in our institution, be prescribing linezolid. And so it gives some sort of precision education, right? When we talk about learner-centered and patient-centered, it's marrying the two. And I think it offers an example of like the potential of how these dashboards could be used. I want to also recognize some of the other institutions that are really thinking thoughtfully about this work, and a lot of those folks are in this room, and we did a presentation yesterday, but Celine Seligalski at NYU, we have Ash Ryder Holly, Stephanie Seebach-Sire, all doing this at Stanford, Joanne Moser, Ben Schnapp at University of Wisconsin-Madison, and Moira Smith and Timothy Lang at VCU. So again, this is just a broad overview, but again, I think there's some interesting promise in how we're collecting clinical performance data of residents and sort of coaching them through that data, and can give them sort of precise learning plans in this big picture of precision education and competency.
All right, so you're hearing a theme, I hope, in thinking about precision education. And the title of this section was how precision education operationalizes CBME. So precision education being how we use data about our learners to drive their future learning. And Ben talked a lot about the 5 core components this morning. And the way I think about precision education is almost like fuel. Data is like, if you think about a steam engine train, it's the coal you stick in the train that you light on fire that makes the train go. Oh, another fire analogy. We got there. And so if you don't have data, and that can be from a number of different sources, as you've seen, it's really hard to actually help our learners grow and develop within that competency framework. So again, think about outcome competencies. Think about the developmental trajectories. They're growing and developing. Martin showed you a bunch of different curves. That's development. The data drives the coaching and the individualized learning, almost like a circle. So if you have data, you can have coaching and individualized learning, gather more data, and the cycle continues in order to fuel that growth and development. So that's where we are. Okay, so I'm going to talk very briefly about something called Simple. And this can be any platform, to be honest, but in using Simple, we've been able to operationalize data about our learners within the EPA framework to drive coaching, individualized learning, and growth and development. So Simple stands for the Society for Improving Medical Professional Learning. It's a QI collaborative, and they work primarily with surgery. That's who they started with, but also peds, emergency medicine, and some other folks now. So this is what the data looks like. And you're getting some identified data here. Don't take pictures of this. But I'd like to shout out Dr. Rushanelsky and Dr. Ryder for being the champions, because they are number 1 and number 2. So this is what the data looks like, and you get the broad overview of, this is the number of assessments you've had in the last however many months. And these are your top 5 of the EPAs that you're getting. These are your faculty, these are your learners, and who are getting the most number of assessments. And these are the name and shame active faculty, et cetera, et cetera. So not the most important part. So say you pull up a resident who has a ton of EPA data. And you look at it and you're like, wow, I can see each and every one of the EPAs and how many assessments they have, the average involvement rating, which is on a supervision scale, and the number of unique raters, so how many different people are actually giving them these assessments, and the last time they saw it. And then you look at the average, you can click into one of the EPAs, so manage the emergency department flow, and you look at all the most recent ratings and you get all of the ratings and the comments. So again, this helps you as your competency committee sits down to look at all this aggregate data and say, here are the patterns, here are the things I'm seeing, here's the narrative. Does that align with what we're seeing as far as the ratings, et cetera? How do I use this data to drive, again, their growth and development and fuel that coaching and individualized learning? That's not the only thing we're doing though, so that's just the baseline. So thinking about the future, being able to build an AI model to actually predict what the next competency score is going to be, what the next rating will look like, and build out phenotypes of learners. So you have these EPAs that are mapped to all these different milestones. If a learner's struggling with a given set of EPAs, and they map to the same set of milestones, if you look at the root cause to diagnose the learner, it's probably gonna be a pretty similar phenotype across those who struggle with very specific things. Maybe it's 6, 7, 8 different kind of phenotypes, but it helps you drive that individualized learning. And how well does this work? Pretty well. So the area under the curve for predicting a score is actually 0.72, and they are PGY agnostic. So this isn't looking at PGY year, but it does actually bear out that, your PGY1s are going to be lower than your PGY4s. And this is getting better and better the more data we feed it. But you're able to see, so this is just an example from surgery. If you look at the ability to predict a score on, ventral hernia repair, you're able to predict that with a 92% confidence what the next rating will be. And the more ratings you have and the more unique raters you have, obviously makes sense, the more accurate your next rating is going to be. If you're able to predict future competency scores, those curves that Martin showed you, you're able to build them out much more easily, and you're able to actually identify residents who are going to struggle in very specific domains much sooner. So the earlier you're able to intervene and work with those trainees, the better able you are to help them, again, grow and develop using data in order to drive that coaching and individualized learning. This is how we actually get competency-based education off the ground in a way that's really meaningful for our learners and our patients, as Dan alluded to earlier. So with that, we're not to break yet. I'm going to have everyone come back up here. We're going to take a couple minutes to answer questions, and then I'm going to send you off to your break, and then back to your groups. So, questions about precision education? Oh, John, right in front. You are.
Maybe you haven't gone this far yet, but in the simple report, where you have EPA ratings over time, you can imagine different patterns, right? Like we might all think that things are going to accelerate over time, 3s, 4s, 5s. The one that you showed had them scattered, 4s, 5s, 4s, 5s, 4s, 5s. Do you in your analysis of those reports, do you think at all about the trajectory as well as the threshold?
Yeah, so we definitely do think about the trajectory. We're not 100% there because obviously, you look at the data and you would like to think that it's linear. Martin, when's the last time you saw a super linear curve? Never, okay, it doesn't happen. So you're gonna see kind of a scatter plot. It's one of those things where, again, we talk about the paintings and pointillism with all the different dots. In order to get the picture, you need a lot of dots, and you basically need a scatter plot to get a good curve. So thinking about, the slope, the trajectory, and I think it's gonna be very interesting to look at, are the curves different by EPA? Are they different by different phenotypes of learners? Is it, you have learners who struggle in very specific things and you actually can see their curves kind of reflect one another over time. And we are gonna need probably multiple years of data to look at that. But that is something that is going into the next iteration of kind of how we're going to be developing the AI model. That's true. There's also a big program evaluation piece that goes into this.
Hey, everybody. I'm Max Batafor. I'm the Director of Educational Informatics for U of M's Med School. And so I might actually amend your earlier statement and add a corollary. If we're going to extend the fuel analogy, there's a quality to the fuel. There's an octane rating. If we switch from coal to gasoline, there's an octane rating to the inputs that go in here, both in terms of the amount of fuel you feed the engine and in terms of the quality of the fuel itself. And there is a huge aspect of garbage in, garbage out. And the more we start to deploy AI, which yay AI, I'm all for it. I love it, it's my meal ticket. But the more it's going to be so important to upfront identify the quality of those EPA ratings that are going into the system. Because your AI will happily predict that the score is going to be a 4, but that won't mean anything because the 4 doesn't actually, the 4s that are being input into the system don't mean anything. And so upfront feedback quality assurance, I think, is going to be huge the more we try and draw insights from these ever increasing amounts of data.
So thank you for teeing me up for that, Max. It's like I planted you here. I will say that we have, in thinking about our next round of funding and the things that we want to look at next, this is actually a big part of it. In thinking about, it's not just the EPA ratings. As you heard earlier, CBME does not equal EPA. It's the programmatic assessment. So thinking about how you aggregate EPA data, multi-source feedback, the EHR data that we just talked about, procedure logging, all of these different things. How do you bring that data together? How do you include narrative and quantitative data in those models in developing these phenotypes? And that is actually kind of the next big step, is how do we actually use this modeling for programmatic assessment And it's not just thinking about the validity and the reliability of each individual piece and the quality of each individual piece, it's the quality of the whole thing together. And if you've read a lot about programmatic assessment, that's a big kind of area of ongoing study and debate. I see the mic in the back.
Yes, hi, I'm Mike Casara from Northwell Health. The thing that's been resonating with me throughout the entire conference, and this is maybe more a visionary concept, but I'd love to hear your opinion on this. The richness of the data is very important, and so these different qualitative streams that would come in would really be fascinating, and the technology is really growing, the use of the dashboards. So we've been talking about numbers and even then talking about text data, but I'm curious about like the smart learning environment of the future, either the clinical environment or the lab environments or the simulation environments that have the AI and the ambient listening and then the video capture. And could that conceivably someday actually, we were talking about burden before, imagine like relieving that aspect and the ambient sort of processes of video capture or text is pulling that in, and then the coach, faculty member actually just gets a pull down of that. They see it in real time, but now they get this other thing that they triangulate with what they saw, and then they can just do the coaching that they really love to do. I'm curious if we're close to that yet.
Okay, so, and I'm gonna be mean and make Ben answer this. Yep, so Ben and I wrote a paper about Moneyball, basically, in medical education, and I think that's a lot of what you're getting at, and Ben was the lead author, so I'm gonna make Ben answer the question. So.
I like baseball, and I got a chance to write a paper about baseball with Holly. We have competing teams. Yeah, I mean, so you see this in other spaces. I think there's always danger in drawing analogy from other fields, but there's also promise too, so it's different things. There are people already working on this kind of thing, ambient AI. People have done it with running codes and team dynamics. There are haptics where they measure eye movement for radiologists or reading chest x-rays or even talking to concerned parents with eye contact and laparoscopic surgery and things like that. I do think we will eventually shuttle off some of the burden of assessment, and we'll have ambient AI that not only collects the data, but then AI that helps us analyze it. One thing that I would love to be thoughtful about as we move through this area is the effect of that. So we've talked, a lot of what we talked about is in terms of like assessment burden or dual purposing of assessment are very human challenges. So what happens to humans when every single moment of their life potentially is being analyzed? And what is the sweet spot of getting a lot of data, but not making every space assessment data? Or how do you take some of those data streams and use it for coaching and it never makes it to a competency committee and some of the data does go? I just think we need to be thoughtful about that as we develop those data streams.
All right.
Just kidding.
Never mind. No other further questions? Okay. It is break time. I would like everyone to come back at 3:10, that is 10 after 3, and then we're going to send you to your breakout groups to get your questions from 5 to 3. The group leads have heard me say this 100 times at least already. 3 questions. Okay, go.